Hello, everyone. Thank you for joining us today. I'm so excited, Sasha, you could join us. I
Yeah,
know
me too.
both of us have been fielding so many phone calls, and so it's always easier just to put together a webinar and answer people's questions. And so, with that in mind, we are going to be going over, sort of where this came from, understanding sort of how this fits into broader healthcare. And we're going to actually go into some of the details of what this means for all the different stakeholders in the medical cannabis space. Ready to get started, Sasha?
Ready? Yes.
So if you feel confused, you know, don't feel self-conscious. This is confusing, and there hasn't been a lot of information. The topic that we're going to discuss actually came from a comment during President Trump's executive order press conference that was made by Dr. Oz, that he talked about the creation of a program at CMS. Now, this language is not actually in the executive order, which I'll get to in a minute. And so, people have, I think, projected a lot of hopes and fears into what this means. This administration, if you remember, in 2022, Congress passed the Medical Marijuana and Cannabinoid Research Expansion Act. And that bill actually removed a lot of barriers for cannabis research. It created legal protections for medical professionals, and it actually called on HHS and NIH to conduct cannabis research. And so part of that uh, requirement was that HHS and NIH were supposed to create a report and send it back to the Senate Help Committee, which they did. But what I think is the more interesting component here is that this bill actually said if there is extra funds, if you have the funds to start doing this research, you can start doing it. And so this is sort of part of the mandate by which Dr. Oz is operating under. And again, a lot of people don't necessarily know that the uh, that this Research Act also expanded the rights for medical professionals. For years, doctors have been able to recommend medical cannabis under the protections of the First Amendment, which is what was upheld in a court case when the Department of Justice actually, after California passed the first medical cannabis law, the Department of Justice came out and said that they were going to prosecute any doctors that participated. And so for years, the only protection, again, that medical professionals had from federal interference or losing their license for recommending was under the First Amendment, which is why we're excited to add it into the Research Act. What is access in the United States currently? And before you weigh in whether this is a good or bad thing, I think it's important to note that the last time we had a federal medical cannabis program was actually it was started in 1978 by the FDA. It was an investigative new drug program called the Compassionate Use Program, which supplied medical cannabis patients with medical cannabis that was grown by the federal government. And it was a small program that was gaining some traction until it was actually closed down in 1992 by Bush Sr., who said that it was undermining the drug war. Actually, his FDA appointee did. And so that's what actually, that was major reason why medical cannabis advocates turned to the states and this whole state experiment began. And so, now here we are. We have, 49 states have passed some type of medical cannabis bill. But, within those sort of variations in color, there's major differences in access. But today, there's over 6 million patients that are participating in the medical cannabis programs. 22% of veterans are using these programs, while 82% said that they think it will be legal. And we know that almost 2/3 of medical professionals recognize that there's some value with cannabis. Also know, though, that there are millions of more Americans that could be benefiting from cannabis treatments. And so as our nation is dealing with some pretty heavy health crises, like we know that this country is in pain. We know that there are several medical conditions that we don't have FDA approved treatments for, and that we're seeing, real impacts of these diseases, including an increase in suicide rates for people with chronic pain. Uh, we know that there are, for some people, opioids are the perfect answer. For others, um, it is a hazard to their health and potentially cause hospitalization or even death. But when we look at like why people are turning to cannabinoids, if you think about all of the people who are suffering in this country, here's an option that actually it itself is polypharmacy, right? It's treating several symptoms. And this is important when we look at how many medications Americans are on and what is the real cost of this? When you look at, 9 out of 10 of these drugs aren't curing the disease. And if we're throwing multiple prescriptions at them, there's a cost, not only financial cost, but also, we're disrupting the lives of millions of Americans when we're sending, 750 seniors to emergency rooms every day from side effects of their medications. But there is a financial cost, important, especially when we're talking about our healthcare budget. And we know that medical cannabis can play a role in both, reducing the pain of this country, but also the pain of the bill of our healthcare. And that is where this pilot program is coming from. Look at the real world evidence. Like we know after 30 years, we can see patients turning away from other pharmaceuticals. We're seeing better patient outcomes. We're seeing that, they're replacing cannabis or they're replacing other prescriptions with cannabis, which again means that they're having fewer side effects, but also a smaller footprint in our national budget. When you put all of that together and know that, the FDA has even said that, none of the harms that they have found outweigh the benefits of people having access. And so this is a big change from when we started. This isn't just a battle that we're talking about in the United States. Part of the conversation around real world evidence is also looking at sort of a global trend, looking for more suitable medications that can address these complex diseases. We also know that in this, the states that do have medical cannabis programs, they're not serving everyone that they could. This is sort of the pathway of all of the barriers that could come up before you become a legal medical cannabis patient. And when we look at something similar within the hemp market, there's a lot of questions around the safety of these products, around trusting what is on the label. And so this is part of sort of what was coming to a head that we saw addressed in the executive order. We're starting to see a trend of states start passing laws like Ryan's Law, allowing the use of medical cannabis in hospices and hospitals. This is an exciting trend, but we're seeing several states jump on this year. This is still a major issue for patients determining whether to use medical cannabis in some cases, and in other cases of whether they will go to the hospital or maybe they'll delay a surgery because they don't want to lose access to their medication. We also have seen with the adult use markets sort of sharing the regulations that often patients' medications are out of stock. They're just not carried by the adult use market. And I think that's because they're different products, right? You don't really hear anyone talking about taking a cannabis suppository before they go to a concert. While for many patients, that may be the not only the best way, but maybe the only way that they can receive medications. It's important to also note that just because we have all of these state programs, it doesn't mean that they're affordable, right? Like even if it was legal federally, if the federal law required everyone to stay in these interstate components, many people who would benefit from medical cannabis are living in poverty, and we can't expect them to be able to pay out of pocket, which is why the sort of dietary supplement pathway for medical cannabis can be a little tricky. It's not legal under federal law, and so there are real to patients not having rights or protections. So there's no protections under the American Disabilities Act. So it's another major issue. We know that this is helping veterans, but again, they're currently have to pay out of pocket, not just currently for their doctor's recommendation, because the VHA is not allowed to write recommendations to help veterans participate in the program. But of course, there's also not insurance coverage. And we have The same thing with seniors. We know that this is the fastest growing population that's turning to cannabis therapeutics for care, but there's real issues with paying out of pocket for doctor's visits, ID cards, and then of course their medicine. And under current law, active military is completely prohibited from using CBD products or participating in their medical cannabis programs. And for individual patients, often can't leave their state or maybe even their home. If you're a medical cannabis patient, it impacts decisions you make about the school you're going to go to, about the jobs that you take, about whether you can travel to go to a wedding or funeral, graduation, and that won't change until we change federal laws. And so that brings us to the executive order that Trump signed in December. There were a lot of speculations about what this executive order actually did. If you just read the headlines, you'd be very surprised to know that it didn't actually change the scheduling of cannabis to Schedule 3. It actually directed the Attorney General to finish the rescheduling process that started under the Biden administration. It ordered the president's deputy chief of staff to work with Congress to try to expand the definitions under the hemp laws to include full spectrum CBD. So that would have to happen through an act of Congress. And it ordered HHS to develop research methods and models utilizing real world evidence, which is what we're going to be talking about today. Over the last few months, we've heard people really confuse a lot of different issues. So the program that Dr. Oz mentioned is separate from the public comment period that closed at CMS that actually took away a statute that said that you could not deduct cannabis products from or make it a part of your benefits. And this language, while it created a potential definition that could impact the program that Dr. Oz was talking about, it is a separate program. And so again, this is just saying that it doesn't prohibit including these products as long as they were legal under federal law, potentially under state law. So in the executive order, Trump really spent a lot of time talking about wanting to increase medical cannabis and CBD research to better inform the patients and doctors who are using it. What's exciting about this context is that we're talking about utilizing real world evidence and really looking at the patients who are currently using this. And that's why I'm so excited Sasha's here, because this is in her wheelhouse and something that Realm of Caring has been participating for a bit. Other sort of lead up that created some of the confusion, of course, was the language that was added to ag appropriations that closed, what many people called the loophole in the hemp laws, which, on one hand, dealt some of the synthetic products. It closed the loophole for the intoxicating hemp products, but it also, along with that, closed the sort of full spectrum products. While Trump, his executive order addressed this issue, right, that patients were going to be affected, and he called on his staff to try to correct this. The reality is that Trump cannot reschedule cannabis, right? He can't, that's not something that's under the power of POTUS. That actually falls under Congress or through the process that Biden started, that he asked to kickstart, but he can't actually step in and change how Congress just defined hemp, because that's a modification of the Controlled Substance Act. And there's also a political hotbed around this issue. Right before Congress passed the language to close the hemp loopholes, we had 39 attorneys generals weighing in saying that they wanted to see these loopholes close. And right now there's sort of a disconnect between the White House and Republican leadership in the House and Senate around these issues. What that looks like in reality is that before Trump issued the executive order, he had letters coming on his desk from House Republicans that were saying, in the name of youth, do not move the rescheduling process forward. On the Senate side, 22 Republicans who had sort of a more interesting take on that, including that this would help China, called on the president to not move forward with the rescheduling process. But why this matters is that signatories on that letter actually have pretty high positions in the current Congress. Everyone in sort of Senate leadership has weighed in on scheduling and is against it. We have everyone that is that's chairing the key committees that relate to cannabis policy right now. CJS, agriculture, and health, which oversees HHS. So I'm getting there too. But the last thing I wanted to mention is that while the executive order did direct HHS to move forwards with these methods, there was another caveat to this language, which was that this had to be funded through HHS's budget and implemented consistent with federal law. Those are two of the major points that are going to impact what this pilot actually looks like. So this takes us back to the executive order and comment we heard from Dr. Oz and sort of the mystery that is around that. Now I'll hand it over to Sasha, who is going to give us a little bit more context and a whole set of new terminology to learn.
What we all collectively want is this medicinal acknowledgement and pathway at the federal level. And I am just so sorry to say that with that is going to come a lot of different acronyms because we are in a new kind of sector. But if this is the pathway that is the ultimate goal is this medicinal coverage, then it's just a matter of getting used to this new terminology and new language. But I would like to think that those of us who are in the cannabis space sort of have a superpower when it comes to acronyms because we use so many of them every single day.
Good point. Good point.
Yeah, so it's just a few more that we have to add in there. So I found this very helpful to myself as I was getting to know, is just kind of doing a deep dive in those different acronyms that are used. And so what I'm going to do now is just go through what those are for you to understand as well, because whether you're a product company or a patient or a provider, this is just going to be the terminology that we're going to be hearing over the next year plus. So it's just good to get used to it now. This all starts with CMMI. So CMMI, the Center for Medicare and Medicaid Innovation, operates through the Center for Medicare and Medicaid Services, which is CMS. And they have this role to always test new payment and service delivery methods. And they have the goals to improve care, lower costs, and then making sure those payment systems are promoting patient-centered practices. And how do successful demonstrations become permanent? Under the Affordable Care Act, the HHS, or the Secretary of Health and Human Services, has the authority to expand these models if they meet specific criteria regarding cost, quality, and care improvement without requiring any new legislation. So essentially, if they can reduce the spending while maintaining or improving quality of care, then these demonstration models move to permanent models. So ACOs are accountable care organizations. So the CMS creates and administers Medicare shared savings programs as well as other models that form what are called accountable care organizations. And so accountable care organizations are a group of doctors, hospitals, and other healthcare providers who voluntarily collaborate to provide coordinated high quality care to Medicare patients. And then they're also going to be receiving financial bonuses for lowering costs while improving the quality of care. So, and just so we're aware, I wanted to throw this in there that they are bipartisan. Why is that important? Because if you're an advocate on this call and you want to help move this forward, no matter who you're talking to at the leadership level, there should be support on either side for this. And what makes it bipartisan? Because it includes cost savings, because it's focusing on pay for value over volume, and then it's also focusing on the prevention and management of chronic diseases. So just very important things that can be aligned on either side of the party aisle. And their success will be determined on the social determinants being combined with medical determinants, ensuring that the care models are collaborative in nature, and then understanding what's not possible on pay for service, that you have this virtuous circle with all of the parties who are involved within the accountable care organization. And then also this idea of deprescribing. And so I know that, Steph, you mentioned this a little bit earlier. So we have an issue with the level of prescriptions that Medicare population individuals are consuming on a daily basis. And so typically, well, right now it's about 4 medications per day with those who are just over 65. But then as you age, as you get older, that increases. So those who are 80 years and older are taking approximately 17, I think it's 17.1 medications per day. And so ACOs, part of the success determination is if we are actually deprescribing medications for people. And so we know, again, through what Steph had explained earlier, that this is probably a pathway to do that if we're focusing on cannabinoid therapy. So that takes us to this ACO REACH model. So within the accountable care organizations, you have these different demonstration models that are being tested out by CMMI. So this one is the REACH model runs for 4 performance years. It started in 2023, January 1st, 2023, and goes to the end of 2026. So that's 4 performance years. And what this is doing is providing these tools and resources for providers to work together within these ACOs to improve the quality of care for people who have original Medicare. And so this is including providers, primary care, specialty care physicians, and it's encouraging those healthcare providers to come together to form these ACOs to break down the silos. So that way it is collaborative in nature. So how's success determined question that I asked before, if they're collaborative and we're not operating in silos. So it's coordinated care to patients to improve outcomes and to manage their costs. So in this performance year, there are 74 ACOs who are participating in this REACH model, and they will not be accepting any new applicants into this performance year as it stands right now. And there are providers operating in all 50 states as well as DC and Puerto Rico. Yes, and then that will take us to, okay, and then we also have this other enhancing oncology model. And so this one is it started in 2023 as well, but then it was just renewed in 2025. And so for this one, this is focusing on Medicare patients who are receiving cancer care. So this is to improve their cancer care so lowering costs and improving quality of care for those who are experiencing a cancer diagnosis and are 65 and older. So now that takes us from the ACO REACH model, which is sunsetting at the end of this year, this takes us to the ACO LEAD model. So those who are within CMS are always considering, years ahead. So this is going to be the new model that is developed because what was recognized throughout the REACH model is that while, yes, there were lower hospitalizations, there were reduced ER visits, there was an issue making sure that they were reaching out to these smaller rural communities and independent practices. And so the LEAD model has been developed to be more inclusive of providers in these rural communities. And so there'll be improved benchmarks, prospective payments, and other innovative policies that will take place for those who are addressing complex health needs to benefit from better coordinated, accountable care. And so the LEAD offers participants this other option, which is called the Benefit Enhancements and Beneficiary Engagement, BEI, another acronym for you, incentive that supports the delivery of coordinated, proactive, and preventative care. So this will start January 1st, 2027, alongside the LEAD model. So what is a substance access beneficiary engagement model? So as a part of the updates, this model will give people the option of consulting with their patients about potentially using eligible hemp products. So the implementation of this model and any dispensing would be funded entirely at the participant's expense. And so by participant, I mean practices. Those aren't the individual people, they're the providers and the practices. And the CMS is not covering the cost of these. So I think that was also a little bit of confusion when we hear CBD reimbursement, assuming that the patient pays for their CBD and is reimbursed by CMS. That is not the case. It would be the participating practices who would foot the cost. And then also just, it has to be said, I think that the CMS does have their strict program integrity safeguards. So making sure that the incentives are safe for the patients in question. And it will only be available to participants who are in states where hemp is considered to be legal. So what is an eligible hemp product? This is the big question mark. So details we know have not been disclosed to date. It's expected to show up in a rulemaking, but there is a public comment period that needs to take place before anything is implemented. So we do know whatever rulemaking is introduced, It does need to be 30 days before it goes into practice to allow time for public comment periods. And in those public comment periods, it's always a good time, and they encourage at the CMS level people to ask clarifying questions. So if there's anything that's uncertain that shows up in the proposed rulemaking, that it is settled and provided that information is provided ahead of the rulemaking going into effect. We also know that there's some other things with when it comes to the eligible hemp product and considering what is eligible. We have this big hemp law change looming over to take in effect on November 11th. We need to have the FDA weighing in. We also know that SSBCI, the special supplement benefits for the chronically ill definitions, need to be defined for 2027. And so now we need to figure out, so now what do we do from here? And Steph, I'm going to have you step in to help with the product manufacturers part.
Yeah, so I think, again, I said at the beginning, we love educating our communities about sort of what is happening at the federal level, but we both have been getting a lot of calls from product manufacturers who are obviously looking at the November 11th closing of the loophole and seeing if this is an avenue for that access. And so for some it may be, for many others it may not be. And so, to think about whether or not this is a path for you, as Sasha said, there are going to be strict quality controls for these products, and you should be looking at your supply chain. So, is the product, did it start with legal federal hemp, and or potentially, depending on the definitions, legal cannabis at the state level, but most likely the legal hemp. Uh, During the sort of supply chain, was it manufactured in a GMP facility? And this is just sort of standard, whether you're talking about dietary supplements, anything that sort of isn't an FDA approved drug. There's the sort of basic requirement of GMP, and that that you're using like a third party testing for potency, so that the labels are accurate, but also for contaminants, microbials, things that are going to impact the outcomes of these research products, and that you can trace, the batch from seed to finished product. And that's going to be, both to fit under, is this a legal product? Did it stay within the legal supply chain, which we're still kind of waiting to see what that is. And can you trace the testing throughout that process as well? Other thing to be thinking of is that a lot of times people create small batches of things, like, do you have enough of this product that you could be a part of this program? And so do you have enough that could be set aside for an ACO that's participating? And so if you answer the yes to one or think you can get there, the next step would be actually looking for an ACO that wants to participate in the CBD program. So if you're already working with a group of hospitals, doctors that may be interested in becoming an ACO, that's another route, is actually having them apply to become an ACO and to start the project. And I want to be clear that in order to fit under this, you can't just say that you're doing it. You have to have a approval from CMS that you are a part of this pilot, right? You can't just say that you are a part of the pilot. Part of a group becoming an ACO, or an ACO agreeing to be a part of this product, one is that they're willing to pay for the CBD product, but the other is that they are willing to participate in research. And so Sasha, I'm gonna hand this over to you because I know you guys created this protocol for this specific program.
Oh yeah, Realm of Caring. We've been in the serving as a nonprofit for the last 13 years, founded by moms who found a solution for their kiddos who are suffering from different diagnosed forms of epilepsy. Found that solution to be cannabis, more specifically high CBD, and they went from hospice receiving palliative care to health, to back to school, to riding a bus, to riding a bike. And so when they founded Realm of Caring, they wanted originally to help families move out to Colorado, where we're headquartered, to get access to medicinal use at the time. So a lot of families with small kiddos, also with different diagnosed forms of epilepsy. Then opened a research registry formally in 2016 alongside Johns Hopkins to start collecting data on how people are using commercially available products in their everyday life. And that's what gets us to this point here is that we have been collecting this research for the greater part of 10 years and using it to understand exactly sort of what we think of when we're at the government level of new medical innovation strategies, which is where there are cost savings, where people taking less prescription medications, where there are less doctor visits and ER visits and less stress and strain on the medical system. And so that's one of the many things we've been looking into at research and what got us to this point because we have built a 65 plus or I guess a CBD and aging study to align with this pilot program that is taking place to observationally look at how people, for them self-reporting their potential benefit or their health outcomes, I should say, over the course of a year from starting at a clean baseline of no cannabinoid therapy use to commencing within a month and then taking subsequent surveys throughout a year. So that's something we've been working on to launch at the same time as a CMS pilot program. That doesn't mean, I should say this as a disclaimer, this doesn't mean that this is the survey that providers will be recommending to patients. It just means we have something created to hopefully make it a little bit easier to collect some data. So as a company, if you are having these conversations with ACOs and you're explaining the process of the pilot program if they are unaware, because we have to assume that not everybody is going to be aware of this pilot program, even if they're eligible to participate. So when talking about it, what will hopefully make it easier is if research is to be collected beyond their intake notes or their patient notes with who they're seeing. For them to know that there is a self-reported observational study that has aligned and does have measures that are focused on questions related to this demographic of individual, those who are both experiencing cancer symptoms, but also additional symptoms of this age group that are popular, like mood disorders, sleep issues, chronic pain, and then also assessing the cost savings, the amount of doctor visits, the amount of missed work days. So this is going to be an observational study that is starts off with a clean baseline. So the individual has not yet commenced their cannabinoid therapy, and then they expect to engage in cannabinoid therapy over the next month. And then they take surveys throughout the year. So to all the way to a 12-month survey. And this is compensated for the individual. So they will receive a $25 gift card per completed survey for their time. So if as you're talking with providers, we are working right now on getting our web page. We got the okay to have a web presence on this, so that will be available at realmofcaring.org when it is ready. But if you have any questions, you can always reach out to Realm of Caring, info@realmofcaring.org to see how you can just stay involved with the research that we're collecting observationally.
Great. And I have a link to the research in just a minute as
Oh,
well.
perfect.
And so to be clear, this program, is this a program that's already a part of NIH?
So, oh, that's a good question. Thank you, Steph. So, this is not directly involved with the NIH study that we're working on with Johns Hopkins. However, we have this what's called the National Cannabis Study that's a part of a cannabis and health research initiative. And data that has been donated, including Realm of Caring's own data that we've been accumulating for 10 years, is donated to what is called the data repository. And this is a NIH NIDA funded project. The funding went to Johns Hopkins, and we are a collaborator on the project. And in addition to the long-term observational data that we've donated to the repository, this will also be donated to the repository. And the purpose of the repository is for a couple of reasons. So we can see the trends across different research studies over time. And we can then utilize it. Other researchers, academics can dig into the data to inform future projects and inform future proposal requests within the NIH. So we can just further our larger understanding of health outcomes across medicinal cannabis use over time.
Thank you for that. For patients who are looking at like how do they get involved in this component? Part of is you can enroll in some of the research or encourage others to enroll into some of the work, the research that Sasha was describing. But it's not enough just to, say that there is research happening. It's sort of our patriotic duty as patients to participate in research when it's funding and it's present. And so um, these are actually the studies that Sasha was just talking about, so you can get access to them. But this is somewhere where you can, participate yourself or find, if you're a caregiver and have a friend or loved one who is starting to use these products, it would be great to get them plugged in. It might actually make them feel more comfortable if they're participating in research while they're researching themselves. Same thing for medical professionals. If you're recommending cannabis, getting or CBD, getting these patients enrolled in research from the beginning. You can also encourage if you are going to a healthcare group or a hospital to receive care, encouraging your practitioners to become a part of an ACO. And for medical professionals, if you're working within a group and you want to participate, consider enrolling as an ACO. And so I just really want to stress that this program, this pilot program that we're talking about, is actually something that ACE has been talking about for 2 decades as far as the pathway of moving medical cannabis forward at the federal level within a paradigm that eventually will be reimbursed under these ACO programs. The patients aren't paying for these, if I understand correctly, Sasha, right? The
Correct.
ACO is actually covering the cost of the medication for these patients. This is like a step before real healthcare coverage. It doesn't require someone to have a job, or it's not just a discount. It's actually covering the medication while they're participating in research. And there are, several international models that look like that. And then, I think that there's this sort of bigger component to all of this, which is, it's not just people who qualify for Medicare or Medicaid that I should say this is just talking about Medicare right now. Medicaid is a conversation we'll be having in the future with this pilot. But having a national medical cannabis program that includes a Office of Medical Cannabis and Cannabinoid Control, NHHS, is how we can, move forward with access to whole plant medicines and not have a scenario where cannabis has to try to fit into a pharmaceutical model that is a square peg round hole. And a lot of what we're going to be looking at through the CMS program and through sort of the that would accelerate if we pass comprehensive federal legislation is answering some of these questions. If we're going to go from compassionate use programs, which is what the states are, right? There's not a prescription. There's a disconnect between what is being researched, what doctors are learning, and other medical professionals, and what is actually available on the market. And so to close those gaps, there is work that still needs to be done. A lot of it is just standardizing terminology, but this is part of that pathway. And I think if you've been around Americans for Safe Access any of the last 2 decades, you probably heard me say that, it's not very likely that, we're going to have an end of medical cannabis prohibition where there's, fireworks and a big celebration, but we're going to, kind of move forward one step at a time. And, the importance of having comprehensive legislation like this out there is so that we understand sort of where the CMS pilot fits into a broader strategy for a national medical cannabis program. So, for instance, the Research Act that was passed in 2022, there wasn't a lot of fanfare, unfortunately, when that bill passed. But part of the reason was that we had already accomplished a lot of the asks in the research bill through administrative channels, uh, and that the bill was actually just cementing them and putting them into law. But the only reason we were able to remove those barriers along the way was that we had the legislation. It took us 10 years to pass that legislation. And so I think, having a guidepost of where we're going is going to be important during this time. And our legislation also includes a new schedule, Schedule 6. This isn't something that's come up in other countries because they don't have intensive a drug war as we do. But I will also say that even though there is a big debate on social media in cannabis circles, right now there is not a debate in Washington, D.C. about whether cannabis should be descheduled or Schedule 3. There's a couple pieces of legislation that deschedule cannabis, and there is the rescheduling petition that called for Schedule 3. And those are two separate processes that actually don't interact. This idea of having a national medical cannabis program that is separate from the current FDA drug approval process is actually something that's being talked about in DC. The idea of creating another schedule has been a part of the discussion, as well as creating an alternative regulatory framework. Our legislation actually deals with some of these other issues that are maybe hidden in the debates around medical cannabis that not everyone could see. And so if you want to learn more about this legislation, I encourage you to go to Safe Access for All, look at the legislation. If you like pictures more, there's a presentation you can look at. And we have an extensive FAQ, and I'm always happy to answer those questions. But there's a very real cutoff date in November 11th this year, where the loophole closes. There's a lot of unanswered questions about this pilot program. I have a lot of optimism, as you can see, Sasha does as well, of what it means long term, but it may not address all of the patients who are going to lose access on November 11th. If you haven't had a chance to check out this guidance document for state legislators, we've put together this briefing to talk, to convince the state legislatures or governor's offices to step in with emergency legislation, emergency protocols, to create incentives so that these products can be in the regulated cannabis markets. I said this, you can download this. We also have executive summaries you can use for your advocacy, and there is a draft executive order or draft emergency rulemaking, however your state handles that, as well as draft emergency legislation that, if implemented, could impact the number of people impacted on November 11th. Along with this, we have this set up on our website that you could just send this to your governor or state legislatures or your state legislators. So check that out, because again, we're excited about what could happen, but there's a long road between the implementation of this project, the pilot project, and and of course, November 11th. And then, of course, there's an election going on. And Americans for Safe Access, we don't endorse candidates, but we can let people know who is behind medical cannabis. And so we have a compassionate candidate campaign that has created tools for you to talk to those people who are applying for the job to represent you, and actually get them to pledge that if they're elected, they will introduce comprehensive medical cannabis legislation and advocate for patients in DC. And so I'm going to stop there and look at the Q&A.
As far as when the pilot program begins. And there were rumors that it would start in April, but if it was going to be April 1st, we would have seen something for a public comment period. So, because we need 30 days notice. So it's undetermined when the pilot program will
There
actually
was a
begin.
deadline in the hemp laws for the FDA to kind of weigh in and better define some of the cannabinoid definitions. And we were supposed to see that, I think, February 10th, and we still haven't seen it. And it's unclear. From what I've heard from people inside FDA and HHS, the work is done, like it's ready to be released. But the same week it was supposed to be released, there was a major turnover in the staffing at HHS. And so it could just be that there was a hold on any new announcements being made, that you never know what the sort of political aspect to any delay there is. But that could also impact what is legally defined medical cannabis. And Sasha, one of the questions that I got yesterday talking to someone about this program is, like what is the realistic timeline here as far as, let's say, April 1st, we see the program details released. It would happen in the public registry, so there could be public comment. And then that would mean it would get started maybe May 1st. But the fiscal year ends in September. And so that's a pretty short window for it to exist under any of the programs, well, under the REACH program versus the other programs. So I'm just wondering if you've thought anything
Yeah.
about that.
So it looks like as far as the ACOs, they operate on PYs instead of FY, so performance years versus fiscal years. And so the performance year goes through the end of December, and so that would be the length potentially. So whenever that starts, then the potential length would go through the end of December. But it would be what I've heard as described as a mid-case scenario where you have a short demonstration period because there's enough evidence to show that there is improved quality of care with reduced cost savings on healthcare. And so this short demonstration period then leads into that long-term lead model. And so that was developed. So this has all been developed with the thought in mind that regardless of the length or duration of the pilot program, it will funnel into the lead program that opens up to more ACOs and opportunity in the new year. Which is crazy to say that it's March and I'm already saying the new year.
Right.
Yeah.
Right. And I think there is, again, a lot of questions around what is going to be legal. Hopefully those will be in the details. I know there's a couple comments about whether or not it would, uh, whether or not CMS would be required to go through public comment. And because this is a sort of a new thing for the country. It's a new thing for the programs themselves to have something inserted. The other issue, I think, for people finding ACOs is that they would have to already be funded because there's no new funding coming into these programs, correct? Until next year. And
Correct.
so there's a lot of sort of unknowns there. But I think what is important is that that whether or not it expands into the lead program as a larger program or stays in a pilot phase for a little bit longer. And hopefully, I'm hopeful that people at CMS are thinking through this as well, these sort of caveats. But we should be thinking about this as a long-term plan, right? That this isn't something that because if we really stay within sort of the confines of this being a 6 month, right, protocol, we're not going to learn that much. And so I think what is going to be important, and as Sasha mentioned, like these programs are known to elected officials. It's liked on both sides of the aisle, right? Because you're talking about helping more people and reducing prices, right, and costs. But I think continued advocacy around this pathway is going to be important. Laws around the current CBD from hemp products has been determined already and was signed by the president in the ag appropriations. There are two things that we're waiting for from that bill. One is clarification from FDA and some of those definitions, but we're not expecting a radical departure from what is in those. And remember, FDA can't go outside of what has been described by Congress as the scheduling. So they can better define something in there, but they can't, for instance, add THCA, like move it out of the THC definition, right? They're going to be confined to those definitions. And sometime before November 11th, we're supposed to see documentation from the secretary with more definitions. But again, it would have to be in line with what is in that law. And so November 11th is currently the date for that. There's a couple bills that have been introduced to delay that bill, but I will tell you, I just don't think it's very likely. And of course, I'm not, we're not advocating against those necessarily, but I think what we have to really do right now is take a realistic look at what the marketplace is going to be look like for patients in November. These non-intoxicating cannabinoid products to be available, whether it's hemp or cannabis market. I think that's going to start dissolving here pretty soon. It's more of a state definition. If you are talking to your state legislators or members of Congress about hemp issues, just be aware that they are tired of this issue, that they have felt like there's a lot of people advocating in the name of patients. So a lot of people are saying that patients want we want intoxicating beverages, that that's medicine. And so, just be prepared for some skepticism. It's nothing new, but just know that you're gonna have to stand your ground and be like, I am a medical cannabis patient, or I am a patient advocate, and this is a real topic, and I need to be heard as a constituent on a healthcare matter, not on an intoxicating product matter.
Well, there was one good question about, is there a fee for service for joining the research
Yeah,
from an
go for it.
ACO or company? No
Yeah.
fee. It's already built. It's ready to go. And I know there's other questions about some education, but this is all going to unfold as the rulemaking comes out. But I would say in that public comment period, if you see something that you either disagree with or you have questions about or you think needs to be more thought through, to encourage you to use that public comment period to inform CMS on your own insights and background.
Yeah, and just on the public comment topic, I want to prepare people that the public comment period for the rulemaking around this program, um, it is not like the rulemaking or the public comment period around rulemaking around the scheduling of cannabis, right? Meaning that it's that most of the time when there's a public when there's something that's posted to the public registry for public comment, it becomes law. Now they may they may listen to the comments, which is why, Sasha, her advice is so important. That if you say this isn't going to actually work, as long as it doesn't change the program, right? They can actually just make that change and move into the program. And so if if I would just say if you feel like complaining about it on social media, you should probably turn it into public comments as well, right? Because those people can actually change it and hear it. They may not send you a bunch of smiley faces, but they actually can make those changes. But there's not going to be like a hearing afterwards, right? It's just going to become law. So, Sasha, any last thoughts?
I just, you know, just keep on staying updated. It's going to be moving, it's moving quickly. And thank you just for being here. And thanks, Steph, for creating this space for us to do this. I hope everyone found this to be a little bit helpful.
Wonderful. And
Yeah.
Sasha and I were talking about this being a resource that people can go back to. So I'll be putting up a version of this on our YouTube that won't have the skipping slides, just so you can refer back to it and stay on top of this. But we'll also, as updates happen, Sasha and I will be jumping back on and providing people feedback. And I just also encourage people, as news unfolds, check the sources, and don't just read headlines, right? Because most of the headlines around the executive order was that Trump rescheduled cannabis, and so that isn't what happened. It might be fun clickbait, but um, we are inside now, right? Like everything that we've been working for to be recognized by our government is happening, but that means that things are not yes or no. They're not up or down. They're not, I approve, I disapprove. So that means you have to read the whole document. It means that, you have to help us educate others. And that means instead of, letting things, boil down to a I like it or I don't like it discussion on social media, that we stick to the facts and that we see this for the opportunity it is, which is to bring medical cannabis into our healthcare system. So thank you, Sasha, for the work that
Thank
you
you.
are doing around this and have done. And yeah, everyone stay tuned.
Yes. Thanks, Steph.
Thank you.